Okay, good morning, everyone. My name is Rumbiza Ichakanyuka, here to train on the process flow from the time the patient gets here from up to the time they are discharged. Okay, so we'll start. Okay. All right, so the training objectives, by the end of this training, we should be able to understand the role in the patient flow. Everyone should be able to understand their role in the patient flow, what you do, what you're supposed to do from the security, reception, nursing, to the nurse aides. Okay, we also should be able to identify emergencies from the security as well. Everyone should know who is an emergency and who is not an emergency. We should also be able to communicate efficiently and effectively across departments by the end of this training. So we just look at this picture here with our security guard. We call our security the first point of care. This is the first person that the patient meets when they get here. Before they meet the reception, before they meet the doctor, they meet the security first. So the service they are going to get from the security is going to determine their reaction before they even go to any other department. So the role of the security guard, the guard is not just security. They are the first screener of patient seriousness. So the key responsibilities of our security guards, firstly, to greet the patients professionally, to observe patient condition immediately, and direct patients correctly and quickly, and also to escalate emergencies without delay. I've noticed a trend where patients just come in, go to the parking area by themselves. They don't even talk to the security. They just go where they are going. Okay, so we are saying, no, this is not correct. As the security guard, you are the first point of call for our patients. So you have to meet them. You have to screen them first before they get into the accident and emergency unit. Okay, so what the guard should look out, these are what we call the red flags. We are saying the immediate emergency signs that you see at the security, at the gate. Emergency, heavy bleeding, difficulty in breathing, unconsciousness or confusions, seizures, convulsions, stroke, severe pain. You see someone is in pain and you know this is an emergency and you should know what to do. So these patients, we are saying the emergency patients with these conditions, they don't queue and they don't go through the main entrance, right? So what's the action flow here for the security guard? We are saying the patient arrives at the gate, the guard observes the condition of the patient. We just don't want our security to be sitting in that guard room without meeting patients. They have to go to the car of the patient and see the patient that's in. You are allowed to ask, who's our patient here? You are allowed to see the patient then so that you know where to direct them, okay? So if the patient is an emergency, we are saying the patient should be immediately directed to the A&E emergency entrance. And you also should alert the nurse aide. For now, you alert the nurse aide verbally. We are going to put our buzzers in the security room where you buy where there is an emergency so that you alert the nursing staff. But for now, you alert them verbally. So if the patient is a non-emergency, you direct the patient to the reception entrance. We are also noticing a trend where non-emergency cases are entering through the emergency entrance. This is because they have not been directed. They don't know the entrance that they are supposed to use. Okay, so I have our security guard here. I'm not sure if the picture is clear. This is the proper way to do it. You greet the patients, you check and see the type of patients that are in the car or that are coming through the gate. Right here, I have two patients in this picture, as you can see. In the first picture, we have two ladies sitting in the car. Then in the second picture, we have a patient here lying on the other lady's legs. So maybe we could just make this a little bit interactive and I would like to ask on these two patients, who is an emergency and who is not? From what you're seeing from these two pictures. You are assessing, you're seeing two ladies entering, sitting in the car, and the other one is two ladies entering, the other patient is sleeping on their laps. Who's an emergency? Yeah, that's right. So when you see a patient like this in the car, automatically this is an emergency. You direct them to enter through the emergency entrance, right? So that is what our security should do. We don't. We've had so many cases where we are having service asking them, did our security guard direct you? And they will say, no, we did not meet anyone from the security. So we want to avoid that. Every patient should see our security. They should be directed by the security to the appropriate entrance. Okay? Thank you. Then we move on to the next stage, the reception. So we are saying the role of the reception staff. The reception is responsible. Reception, you are the first formal contact of our patient. You are we call you the face of the organization because you are the first formal contact where you have interactions with the patients. So what is your role as the reception staff? Reception is responsible for speed plus accuracy. You are not responsible for diagnosing patients, no. Then the key responsibilities: capture patient details accurately, identify emergencies immediately, communicate clearly with nursing staff, and also initiating the billing processes. So there are some emergencies that could have been missed at the gate. As the reception, you should also assess to see the patient's condition. Is the patient able to sit on the bench, or is the patient an emergency? Right. So the reception action flow. We are saying the patient arrives at reception, you do a quick visual check to see the condition of the patient. If emergency, you stop registration immediately and call nurse aid so that the patient is taken to the resuscitation room or to our observation beds, right? If the patient is stable, you capture the details. Then you also confirm payment method. If the patient will be using cash, medical aid, or corporates, you know how to do this, and you know the verification process that you have to follow. So we are saying the reception never delays emergency care for payment. If a patient is an emergency, we don't delay their care because we want payments. But get me right here, our role here is to stabilize the patient. A patient comes here, they are not stable, and you take them to the bed for stabilization. We don't expect you to have a patient for 5 days being treated without making any payment because they came in as an emergency. No. Emergency is just the initial consultation and stabilization. After that, we start following up on the payments. Okay? Then here, this is just a picture of a patient standing at the reception with their relative. We have the receptionist and we have the nurse aide, right? So we just want to make this interactive. One receptionist, one patient acting dizzy or in pain. What should happen here? Are you going to register this patient while they are in this condition? What do you do as the reception? Kids? That's correct, because clearly this patient is in pain. We don't expect to see someone like this sitting at the bench or standing at the reception. The relatives can complete the paperwork while the patient is lying down somewhere safe. Okay, so we move over to the third, which is the nurse aid. Nurse aid, we are saying nurse aides, you are responsible for triaging and also vital signs. These vital signs should be able to help you detect the condition of the patient. We want to show our patients that we know what we are doing. So by using these vitals to determine if the patient is an emergency or a non-emergency, these patients will know that, no, we are dealing with people who know what they are doing. even from the nurse aides, before even meeting the doctor. The patient can tell that, no, these people know what they are doing, right? We are saying nurse aides are the early warning system. These patients meet you before they meet the doctors. So your responsibilities as the nurse aides are to receive emergency patients directly to the resuscitation room. Firstly, when those patients are directed from the guard, by the guards, we don't expect to see people entering through the emergency entrance, entering the clinic by themselves. They should be assisted by nurse aides. Okay, so you are the first, you are the early warning system for these patients. You also measure vital signs and identify abnormal readings using these vital signs. You escalate immediately to nurse, and you also assist with patient movement. Okay, so triage basics. These are the basics for triaging. Firstly, you record BP, pulse, temperature, oxygen saturation, height, and everything else that you record. Then you report immediately if you see very high or very low blood pressure, very fast or slow pulse, low oxygen, or altered consciousness. Okay, so these things may be missed at the reception. Some patients come in walking as if they are okay, but you can tell from the vitals that no, this is an emergency. This patient is walking, but they are not fine. Okay, so we have a picture here of our nurse aide recording vitals. So I have these 3 vitals that were taken: the first, the second, and the third. These are all vitals of different patients. So I'll just love maybe to hear from the nurse aides. What do you guys see here? Do we have emergency patients here? Or they are all okay? Let's hear from you guys. You've been doing this, you know these things. Okay, so for the first patient, the temperature is 36.7 degrees. The pulse is 76. Then oxygen saturation is 98%. Blood pressure 120/78. Then the second patient, the temperature is 36.8 degrees. Pulse 84. Oxygen saturation 97%. Blood pressure 210/120. Then the third patient, we have a pulse of 120. We have an oxygen saturation of 85%, a blood pressure of 198/125, and a glucose reading of 280. Yeah. So what do you guys see? Gatitaure, Murukone, Mbarika. Okay, Cecilia. Okay. Okay, it's a dire emergency, right? Okay. Barika, you wanted to say something?
For the second patient, she got a high blood pressure.
Okay.
Yeah, but the other vitals, they are okay.
Okay. So yeah, amongst these 3 patients, they should all be seen by a doctor. This is where we are saying triaging comes in, right? Who sees the doctor first? It's clearly the third patient here. Then the second patient, then we finish off with the last. But we don't just do these things without notifying this patient, because this first patient, who has normal vitals, came in first. So what do we do to make sure that this patient is not disgruntled? They don't feel like you are leaving them out. Muchikoshes among my patients. What do we do? Okay.
I think it's good to explain to our patients that we have an emergency, doctor will attend to you soon.
Okay, thank you. All right. Then we move over to the nurse, which is the clinical care and coordination. So the role of the nurse, we are saying the nurse is accountable for patient safety. These nurses are accountable for everything else that you guys are doing, from the triaging, vitals, and everything. They should be inspecting and ensuring that you guys are doing the correct thing. If anything goes wrong, the nurse is responsible. Okay, so the responsibility of the nurse, we are saying it is important for a nurse to verify the identity of the patient. And here we use 2 patient identifiers. Okay, I will talk about this in the next slide. The nurse also administers medication, they monitor patient response, they coordinate labs and radiology, and they also escalate concerns to the clinician. This is also very important. Okay, so how do we identify or verify a patient's, we want to verify or identify a patient's identity, right? We are saying we don't just ask a patient, are you Letitia Musonza? No, that's not the way to do it. What do? We ask the patient to give us their full name by themselves. We don't ask them to confirm. The patients should tell us their name if they are conscious. If they are not, the relative can do that for us. We also ask the patient for their date of birth. So we use these two identifiers, which are the patient's full name and the patient's date of birth. Then we match these with the system records. We want to avoid cases where people are giving wrong medication because we did not verify their identity, right? So this is a very important part of our process flow. We are also saying the nurse, here we have a picture of nurse administering medication and also doing the identity confirmation process. So I just want to find out from you guys, we are saying the nurse should not just, a patient comes in, you administer medication, you should have some sort of a communication with the patient before you administer medication. So what discussion can a nurse have with patients before they administer medication? Let me hear this from you guys. Yeah, Robert.
Confirming the patient's name.
Thank you. Madam C. Yes, it's okay.
Any allergies? Any medication you're allergic to?
Yes, that's correct. Cecilia.
The nurse is supposed to introduce himself first to the patient.
That's correct. Yes, that's correct. They should introduce themselves. Anyone else? Okay, so we are saying to create a bond with the patients as a nurse, you don't just do what the doctor has told you to do. You just give Paracet, no. You talk to the patient first, you ask them for their name, date of birth, you explain what you know about the medication that you're about to give them. If it makes them nauseous, you explain everything, you ask for the allergies. These are some of the things that could have been missed by the doctor. Okay, and if you notice that the doctor could have missed something during their diagnosis, you are allowed as the nurse to go back to the doctor and communicate with him. No, you missed this point, this part here, the patient is allergic to this medication that we are giving them. Okay, so communication between departments is very critical. We should always communicate from the security, the nursing staff, the doctors. We should be able to communicate across departments so that we don't inconvenience our patients, okay? So now we have our nurse administering medication after the initial communication. So here we just want to demonstrate correct versus incorrect patient identification. So the first one here, we have you ask a patient's name, date of birth, and hear it from them. Or you ask the patient to confirm the name and date of birth you see in the system. Which one is correct and which one is not correct?
The first one is correct.
Okay, yes, we are saying we ask the patient to tell us their name and date of birth, and we hear it from them. We don't ask them to confirm, because if you ask a patient to confirm, you might ask her, are you Letitia Musonza? And she will say yes because she's in pain, but she won't be the right patient that you are dealing with, and you end up giving the wrong medication. And so we want to avoid that. Then we move over to the investigations and time targets. So laboratory and radiology coordination, samples are sent immediately after they are taken. They are sent to the lab immediately. This is done by the nurse aide. The nurse aide delivers samples within 5 minutes of them taken to the lab. But the nurse is accountable for this. If you are the nurse on duty and the lab samples stay in the nursing room for maybe 1 hour and you don't tell your nurse aides to take these samples to the lab, you are accountable. If there are any delays on samples, on bookings or everything, as the nurse, we are saying you are the administrator at that point, so accountability remains with the nurse. So, yeah. So here we just have one lady here taking the samples to the lab, and this nurse aide here ushering the patient to the radiology. This is what should happen. Even if the patient is in the right condition, they are working by themselves, the nurse aide should always take the patient to the radiology. We don't want to see a case whereby a patient is directed that you go there, that's where the radiology room is. No, you take the patient there, okay? Ko patient ikarasika kenda pharmacy. Okay, then we move over to the discharge process. We are saying the clinician authorizes, this is the doctor authorizes discharged. Instructions are explained clearly to the patients. We don't want our patients going home without understanding what was happening to them, why they are being discharged or why they are being transferred. We want the patients to understand, and we also want the billing to be finalized by the reception staff. Then the patient goes home. If the patient has been admitted for daycare, you do what you're supposed to do, get the deposit. I think we do have a document which communicates about that. Then for referrals, we are expected to to have these patients transferred within 15 minutes. We don't want to see patients, the patient has been referred, but the patient is here maybe the whole day before they go to where they've been referred. No, we want patients to be transferred as soon as they are referred. Please, thank you. Wait, okay, it's fine. Then this is just a picture here, discharge discussion, billing desk, patient exit flow. Roba, you wanted to say something?
Okay, I wanted to ask,
okay.
if any transfer that the patient should be transferred within 15 minutes.
Yes.
What if it happens that the relatives organized for an ambulance and the ambulance delays for maybe for over 2 hours or so? What should we do?
Oh, that's not acceptable. You guys will need to organize another ambulance. If the ambulance that is delayed is our BMC ambulance, we need to know why. But if it's not, we cancel that one which is delayed, because these are emergencies. We don't transfer patients that are not in pain, that are not emergencies. So clearly, if they are delaying for something like 2 hours, we need to find a second option. You will notify the relatives that no, your ambulance is delaying. We need to find some other service provider that we can use.
I think Roba is not in the open with a particular case. We are talking of cases where relatives come and sometimes they portray agents in the patient's management, and they promise to pay their, settle their bills. And in due course, we realize they are not forthcoming, they are not paying, the bill is going up. Then they have a talk maybe with the doctor, and they decide their patient be transferred or discharged, but the patient needs ambulance. And they even they dictate that we are going to use Emirates, let me say, Emirates, because the Emirates accepts premium medical aid. Then that's where the delay now starts.
Okay.
2 hours, they are still waiting for Emirates. Neither can we change that decision because it's money here. What do we do?
Okay, I think on that one, Metron, you will have to, you will need to help me. We need to have a document where if the transfer of a patient is caused by the relatives, they have to sign that document stating that they cannot transfer the patient immediately because they are waiting for their own ambulance which accepts their medical aid, so that the blame will not be on BMC if anything happens to the patient. So maybe we need that document where we make these relatives sign, and acknowledge that they are causing the delay.
I think also something that may help us is for the doctors to be able to communicate with the reception.
Okay.
The events that maybe you see that these people don't have money. You can communicate with the doctor. If there's need for a transfer, it's better for them to transfer the patient that time, unlike to postpone and say maybe let them speak today and transfer them tomorrow.
Okay. I think Metro will need to have that discussion with the doctors as well. Okay. So now we talk of patient rights and confidentiality. We need to respect patient dignity always. We don't shout patient details. We don't shout patient results. And we don't need unnecessary exposure to patients' confidential material. We need to follow the data protection policy. This is something that will be trained at a later date as well. But we are saying basically we need to respect patient privacy as the clinical staff, from the security to the reception. We should respect patient privacy, patient's dignity. Let me just give an example. Maybe you're in the nursing room and the patient comes, it's me, I'm in the nursing room, right? And the patient comes in. I should be able to excuse myself and leave the patient with the nursing staff so that they can discuss. If the patient has something to ask, they can ask freely without seeing me in my clothes standing there in the treatment room. So it's also part of respecting our patients' dignity. So Mbarika, if you see me in the treatment room and there's a patient, you have the right to chase me out, or anyone else.
Me too.
Yes.
Thank you so much.
Yes.
What about if you're in a treatment room, then partner nurse aid, right, nurse,
We also we want to regulate that, yes. Okay, that also should be regulated, Metron. We don't want too many people in the treatment room. Maybe the only people that should be there is the nurse and the assisting nurse aide only, and the patient. Even the relatives, if they are not assisting in any way, they should be out of the treatment room. Because the patient probably has stuff to discuss with the nurse. They cannot do so openly. Yeah. Yeah. Yes, that can be understood.
I noticed sometimes that the patient
that's okay. If the patient requests, it's okay. But there are some cases where the patient cannot chase them out. And it's but if you do that for them, and it's okay. So, okay.
I have a question. Sometimes we have some of these young people who are coming to overshadow.
Yes.
They are not nurse aides, but well, they are dressed like nurse aides, and they're just coming to observe. How best can we handle this situation where they are coming, but again, we cannot allow them to see too much? How best can we address that? Should we ask for consent? Or at least if there are 3 people and they're like, these are some of our team members who are just on standby to help. So at least they also benefit, because if we chase them from every room, they won't be at the doctors because that's fairly private. Now in the treatment room, they are not helping, but they are there. Probably they do help here and there, but not actual touching patients. We don't allow them to do that. But they're there to also observe and
learn. Yeah. Metron, what do you think we should do?
What I think should happen is we explain to these guys who are coming for job shadowing. We stress on the patient's privacy, but we explain the processes to them, even without a patient. So much that when a patient comes, the person knows what is going to happen with the patient, though they are not present during whatever procedures will be done. We explain to them, like, it's very important to observe a patient's privacy. So you find that when a patient comes in, maybe we're learning something in the treatment room, when the actual procedure is being done, you have to excuse yourself for the sake of privacy.
Okay. And also I'm thinking on another angle, maybe it's something that we can also try to do. I think there are some procedures that maybe these guys should really observe, maybe dressings. So I'm thinking maybe we could ask for the patient's consent first before we allow them in. If the patient...
But in private sector, it is very difficult to you take the patient's response with a pinch of salt.
Okay.
Because sometimes they say, me, I want to be treated, maybe if I refuse, they will not treat me well. But in actual fact, what happens, they will start talking, which cannot be used like a guinea pig.
Yeah.
That will only happen in the public sector. But in private sector, you can never ask for permission to use them as a dog.
Yeah.
Some people are very open-minded.
Okay.
Like myself, if it's the leg or the arm, I think it's okay for someone to see, but depends. Some people won't like it, some people won't.
Okay. So yeah, thank you, Metron. You know better. So here, yeah, we have these two pictures here. I just want you guys, let's have a discussion. We discuss what's wrong with these pictures. What do you guys notice? These are two different patients entering. The other one is being assisted by their relative, and the other one is being assisted by the nurse aides. And they are entering using the emergency drop-off. What do you guys see? Yes, Ratius?
Yeah, I think the first picture, there should be a nurse aide assisting them. Since it's an emergency.
Okay. Yeah, that's right. We are saying we don't want patients entering from using the emergency, yes, unassisted. They should always be assisted, like in this second picture here.
I have a question.
Yes.
There's one incident I've observed. A young man comes in from the community. I think you understand what I mean, from the community around. He gets in and he's limping so bad. He gets out of his car, continues limping. One of our nurse aides notices and runs to him. He's like, what's it? And he's like, don't touch me. What do we do in that case? And he had to limp until he got to the reception. So he's like, don't touch me. Yet the young lady was rushing. He's like, let me help you. Can I help you? It seems like you need help. Yeah, so in that case, we
leave him, but stand by them as they limp, because I'm there to just show them that I'm taking care of you, but I cannot argue with them if they don't want to be touched by me. Me, I'm only there to ensure safety. You give that person will not fall.
Okay. Yeah. Thank you, Metron.
I will not touch you.
Okay.
And if the patient falls,
Then we also have these three patients sitting at the bench here. Who are you sending to the doctor first? The one in the middle, right? So this patient clearly is just by observing, this patient in the middle ear is clearly in pain. So we don't want to see patients like this sitting on the bench. There are quite a number of times that I've entered the A&E, the reception area, and I've seen some patients sleeping on the bench. That's something that we should not allow. If someone is like that, you take them to the observation beds. They can be seen by the doctor from there. It's not a good picture even for us, even for the other patients that are coming in. If you see that someone is clearly in pain, the right thing to do is to take them to the beds. We don't want to see patients sitting like this on the bench. If the doctor is busy, especially if the doctor is not busy, maybe you take them to the doctor's room and they get assisted first, because this is not a good picture to look at, even for other patients that are entering. Okay.
Can I ask for the previous picture?
Okay, this one.
Right. The first one, to see the scenario is like that the nurse is busy and the nurse is they are busy. Then what?
They should not be too busy for emergencies.
But the cases must be like that.
Yeah.
Sometimes we get emergencies one after the other. Let's try to attend an emergency, most of the time emergency, and maybe TV2.
That situation is a critical area that we should really consider. Staffing.
Okay.
There is a critical shortage of staff.
Okay. All right.
Because it really happens many times.
Okay.
Sometimes there is a patient that observations where the nurse is attending, and probably to attend also. It's toileting. The nurse is in the treatment room, to administer care, which should be done very slowly. The patient is admitted, and weapon reception is there. Maybe I'll to somebody. Then this car just comes.
Okay. So we are saying this, the second picture, this is the right thing to do. But because of staffing issues, we are having cases where it is difficult to implement. So Metron will leave this ball in your court again to ensure that the staffing issue is addressed. So that,
sometimes suppose that we are doing it. Because I can't give patient information.
But that is very wrong. Yes, I understand the patient will be complaining, but it's wrong. It shouldn't be done that way. So these are some of the issues that should be addressed. Because this is a private institution. We don't want to see Letitia holding the mop at Chikoroba. We don't want to see Letitia doing vitals. So it's something that should be addressed. Maybe Metron, please help us.
I'm only okay. I'm going to contradict myself in this regard.
Okay.
In this particular scenario, that the nurse, the receptionist, goes and takes vitals. The only thing I'm happy about is Letitia is a nurse aide trained.
Yes.
She can understand. Some of you, are you? Are you also trained?
Yes.
But she is not.
Yes, actually. I didn't know. For Letitia, she did nurse aid when I was. This one can even go to the ambulance and also go to Musarabani with them, or call the ambulance.
Chieza. We have Chieza.
Are you trained nurse aid? No, there is a highlight to it that at least if someone doesn't mind someone being, but if you're wearing a uniform, let's say, I think it's okay for them to step out and go. I've been in a place where the nurse aide receives you and then takes you to the, and also works also in the treatment room. I'm going to, like I said, I'm going to contradict myself, but we need to find a common ground where we say, is this what we want or we don't want it?
Okay.
So we decide and say, no, Letitia or whoever, please just make sure the actual nurse aid does the vitals. We need to maybe, again, the ball goes back to
matron.
Yeah.
Because for now, these ladies are not wearing uniforms.
Yeah, they are
It doesn't look nice for patients.
When they are not in uniform, I agree with you.
So, yeah, I think that is all for today. So, just to emphasize, especially on the security, we are saying the patients are not seeing the security. They are not seeing the security. Maybe the security guard is sitting in the guard room. They are just registering cars coming in. They do not have that interaction with the patients. So we are saying these are the first people that should meet our patients and direct them where they should go. So that is the first thing that we need to be corrected. Yes. Yeah.
To get some. I remember during those days of COVID,
yes,
they used to come one hour, and we did not even have like gloves, security, even masks. So I would suggest you to wear my gloves, masks, because no one will infect, for example.
Okay. Yeah, that's okay. That's okay. Then lastly, I have this picture here. It's not so clear here, but one of these pictures is has been put in the guard room. It's just a triaging guidance where you are shown the immediate the patients with immediate and life-threatening conditions, the ones we are saying they are very urgent, the urgent ones, and the not so urgent patients. So we have these posters, one in the guard room, one in the reception area, and another one in the treatment room. This poster should just be able to guide us to see which patient do we treat as emergency or non-emergency. Some of the conditions might have been missed here, but you guys know better. Okay, so maybe we just go take a look at these posters.